I invite Dr. Awaneesh Upadhyay. He is working as a retina consultant at IQ Super Specialty Eye Hospitals in Gurgaon and adjoining areas. He'll be talking about foldable IOL as sutured SFIOL in post-corneal transplant patients.
Yeah, thank you. At the outset, I would want to thank Dr. Devakant for having me for this IC, and I'll be taking you along with one of the 6 fights which we would see how it turns out. So we had this 56-year-old one-eyed gentleman, and he had a complaint of defective vision in the left eye since a month. And both of his eyes had had corneal transplant for 2 times each, and the, the cause for transplant was not known. The right eye, the vision was PL positive, left eye was CF, and previously he had been for follow-ups where his vision was 636. Right eye now has a failed graft, and there is an iridocorneal touch and ectropia on UVA. And the further details are very hazy. The left eye, you have a clear cornea graft, which was recently, maybe 2 to 3 months back, it was nicely done. And now he had a post-operative 636 vision, but now subsequent follow-ups have showed there is a subluxated IOL, and the ultrasound is showing retina on. So we planned that we will do an IOL explant with vitrectomy and a sutured SFIOL for this patient. I mean, this is normally I take up this patient for surgeries. So coming to the video of this patient, you can see we have done the peritomy here, and would want to emphasize that then we start with this. Sorry. Yeah. So we have done this peritomy for this patient, and we have made these partial flaps. This is what I have been taught, and this is what we routinely do for our patients, where and then we make the tunnel. Now this patient was actually very deep-seated eye, and it was very difficult to actually do a very posterior scleral tunnel, and going very close to the graft was also very risky because you can see the graft is very big and it's almost touching the limbus. So we made a corneoscleral tunnel, and it was very close, like it was mostly like a limbal tunnel, you would say. And then we took out the IOL explant, and then we did a vitrectomy for this patient, induced PVD. To shortage of time, I have not shown. And then we went with this ab-externo technique with 4-point contact SFIOL to be done. And this is what we do. We do real loading, and we use these straight needle sutures. And you can see we have, as a previous PI of this patient, nicely deep AC formed. So we take these sutures out, and so once that is out, I'll take we use this PMMA lens with eyelets, 6.5 PMMA lens as are used, and we tie the knots, and we try to actually go in putting the lens inside, and we'll see how it turns out. You can see the trocars are very close to the globe. The globe is high, like it's hardly opened up. So I just have enough space to just maneuver around in that particular space. Like there is no space in either of the areas. So we do this to the other side, and this is where now I need to put this IOL within this tunnel which I've made, and I have to literally go vertical as compared to what normally we tend to. We have some place where we can wiggle it around, and since it's a PMMA lens, I have to be very cautious that I don't have any breaks. So this is what I'm trying to do, and once the sutures are done, I'm trying to push it inside. Yeah, so when I'm doing this, this is where there is a snap and the IOL kind of breaks at the optic-haptic junction. So now I am in a condition where this patient, whether we should leave it a phakic since it's a one-eyed patient, or whether we should have another IOL. I didn't plan for a three-piece initially. I thought I would get away with it. So at this time, I was like, what should we do? Then I thought whether we can actually use a foldable IOL in place of the PMMA lens which we use. So I followed a similar technique where I used a foldable IOL for this, and I did tie the sutures. Now this is another edited version of it where we went ahead, we have done the railroading, we have put the sutures again, and we have tied the knot at the optic haptic, just like 2 millimeters away from the optic haptic junction. And sorry for the video, slightly decentered at that period of time. But yeah, we were able to make the sutures as we did in the previous surgery. I mean, in the previous IOL when we were putting, and now once we have cut the sutures, and then I place it again within the space. Yeah. Just have a minute. This is what I'll show you, and then there's a place. It's a similar technique where we did the railroading, we took the sutures out, and the way we put within the eyelets. No, I did not pierce it. I just no, I didn't pierce it. I put a normal sutures. Now this is what I went back and searched for literature whether some people have done this sort of a technique or not. So this was post where intraoperator, where you can see the IOL is nicely centered, the tunnel is closed. So this is when I went back and I searched for some couple of literatures regarding. There are good literature where they have used this sort of foldable IOLs. Now this is a technique which this is available online also, where they have actually done a similar sort of a technique for a foldable IOL. And instead of making a bigger tunnel, they have used with, you can see the junction at which, so roughly like this, but instead of one, I have put a couple of those. And they have had fairly good visual outcomes. So to say, I mean, so the points to ponder for me now, this is this patient I saw it 2 weeks ago. You can see the IOL is nicely centered. The vision is now 636, 60, 660 are needed. So whether we should have left it a phakic, I mean, I was a bit skeptical about it because this is a post-graft patient. It could be like the visual acuity would be very different. There's a lot of astigmatism in this. We could have gone with three-piece IOLs. This I could have planned. We could have had iris claw or the X-net techniques where you have these foldable. But I still feel that this is also a viable technique in case where you don't have the availability of the IOL, and you can have fairly good results. And if you see, I mean, the thing is, it's like it's a desperate situation for me, and I wasn't anticipating such a deep set eye. So, and all, I think patient is still happy. I think he's still good to go. It's been almost 8 months. The graft is still intact. And what has happened with the right eye graft, I was more skeptical if we go for another surgery, second surgery, whether the graft may go into failure. So now I think he's fairly okay. So I think it can be done in desperate situations. Thank you.
Eye surgery. Sorry.
Yeah, please continue.
Yeah, the way normally what we do. Yeah, just couple of that's the way I showed it to you in that video.
Normally, as in you have not pierced the haptic, right?
No, I have
You've
not.
just tied it.
I have not gone to put a very tight suture so that it would snap or there'll be more torque. But still, it is like decent enough.
That is fair enough. I think once you tie that, there would be a
Yeah, it will kink. I understand.
It will kink and it will never give away.
No, I mean, I didn't go to that extent where to actually, but I did I
slightly kink.
Yeah, it would, but I would not say I would went to that extent to actually kink.
When I saw your first case, I mean, when I heard about your topic, I thought you had already planned it for extreme astigmatism and then you did it. Can it be extrapolated for extreme astigmatism? I mean, we don't have access to toric multi-piece or
So
something.
this is what I was saying. There
That is
are
how it-
couple of
because-
articles, and they have one of the articles they have had around 50 patients where they have done, and the one before that is around 60 patients. So they have shown that the results are fairly okay, and they have not had issues
And
with this.
nobody does this piercing of this, no?
Piercing has not been done in this. This is what
No,
this is where
I
this
mean,
video
you
which I've
read the
shown.
literature, piercing.
Piercing technique is done with that 6-0 polypropylene,
Poly-
where you
5-0
go
or 6-0,
pierces
yeah.
and then you kind of lift it out and then you
PSC
flange it.
is a bit risky at times. I've
Yeah.
tried, not with this lens. I was once doing a CMT flex and the haptic broke.
Yeah.
So then I tried to, it was a bit difficult.
No,
to do
what
it
they
with
are
that.
doing is they pierce it, they use a 6-0 polypropylene and they go through one of the haptics and they take it out, apex steno technique. And the trailing end is again flanged inside. And the one which has been pulled out, even that is flanged. So you are kind of doing the Yamane sort of a technique here. And but with 6-0 this they have done.
I think this
So even
can
that
be,
is fairly okay.
this can be utilized when you don't have the required IOL and you just have this lens in your.
We do encounter a lot of cases which have 4 diopter, 5 diopter of astigmatism.
Yeah, that is a good. I remember seeing a video where they have
So if you
tried
can reduce
toric
the-
IOLs. Yeah.
If you can reduce the astigmatism to, let's say, 2 diopter or 3, but it has to be predictable. The only issue with
Yeah, I mean,
because
the-
of the optic tilt,
It
itself-
wasn't, you saw it was very nicely settled.
No,
So-
I'm not saying that we feel that it's very because
Yeah,
even
yeah.
in normal SFIOL multipiece, we get some times of abnormal astigmatism just because you can slight
The
tilt
tilt
or
is there.
something like that.
The tilt and this astigmatism are very big thing. So what is good about the Awaneesh video is that it's nicely centered. And what exactly we are discussing, too tight and too loose. Too loose, we may end up in losing the lens, and too tight will lead to tilt. But nicely centered IOL, that is
Optic
very
haptic junction, where we are.
No, at least 2 millimeters from the
2
optic
mm.
haptic junction. I'm not very exactly
And,
close.
regarding the toric thing, there are already publications. Gabber's technique, they have already gone, and toric SFIOLs they have done.
Yeah, toric foldable, no?
Toric
Foldable, yeah.
foldable.
So I think we
There are
cannot
videos
recommend it
available.
at the first go but it can be used as a salvageable condition, or maybe it's a
Yes.
desperate situation.
That's
I
why
think
our
that is
IC
what I
is
feel.
X files, na? So
Hidden file.
Because the knots would cause some amount of tilt if
That-
they're not perfectly centered on both the ends.
I think for this we do tend to have it on the outer aspect of the haptic, the way we have it in the PMMA lens. If it is on the interior side, it will cause more, it will cause more traction and possibly cause a mole tilt. So when you are putting it, it should be on the outer aspect of the optic haptic junction. So once your apex turner technique, it will just come on the outer side rather than on the inside where it will start to tilt and start to kink. So that should be on the outer aspect of it.